Welcome. As you all enter our Zoom room, I just wanted to say hello and welcome. My name is Kate McGrail. I'm here from the Community Health and Wellness Division at Suburban Hospital. We are so pleased to have you here for today's program, Recent Updates in Alzheimer's Diagnosis and Treatment. Over 160 of you registered, representing such a strong interest in learning more about the most common form of dementia, affecting over 5 million Americans over the age of 65, as well as hundreds of thousands more of individuals under the age of 65 who may have early onset Alzheimer's. Today, we're here to learn more about current concepts in the evolution of Alzheimer's disease, pathology in the brain, current diagnosis for procedures current procedures for diagnosis of Alzheimer's disease, as well as approaches to finding improved treatments, the importance of biomarkers in the diagnosis of Alzheimer's disease, as well as the potential role lifestyle factors play in modifying the progression of Alzheimer's. So before we introduce our partners and our speaker, I first wanted to cover a few housekeeping items. As you heard when you logged in, this recording or this session is being recorded and it will be shared later this week to anyone who registered. You may also access closed captioning by clicking the CC icon once. You will find that at the bottom of your screen on most devices. Because we are in Zoom webinar today, you will remain on mute. We highly encourage you to interact with our speaker, so please feel free to use the Q&A option to type a question. We will reserve time at the end of the program to respond to your questions. Lastly, the programming we offer is highly driven on your feedback. We kindly ask that you take a moment at the end of today's session to complete a short evaluation. This form will pop up at the end of the session when you hit the red leave button. If you're unable to complete the survey today, a follow-up link will come in an email when you receive your recording. So, did you know that the US Census Bureau predicts that by the year 2035, the number of adults greater than 65 will outnumber children in our country? With a tremendous advancement in medicine, we are all living longer. But we also want to live better, of course. So in a moment, you will hear more about the local village partnering with this event. But at Suburban, we have an initiative called Village Ambassador Alliance that is very much aligned with the local village movement. And that is our desire to keep older adults not just living, but thriving, independent, and empowered. Seminars such as these are one example in which we can support these goals. We are also proud to have invested over $15,000 over the past several years in empowering villages to make advances in aging at the neighborhood level. So now I'll turn it over to Connie Rao, President of Friendship Heights Neighbors Network.
Thank you so much, Kate. And thank you to everybody for coming, whether you are from Friendship Heights Village or from the many other villages that we've also invited. This event, sponsored by Suburban Hospital, is a collaboration between FHNN and the Little Falls Village, but we've also invited all of you because we think this is a topic that we all are not only interested in, but need to know much more about. So we want to thank Suburban. We want to thank Dr. Albert, who will be speaking soon, and welcome to all of you on behalf of the village's movement and all of the villages that are represented here. Thank you so much.
Thank you, Connie. So now I have the honor of introducing our featured speaker. Dr. Marilyn Albert is Professor of Neurology at the Johns Hopkins University School of Medicine. She is Director of the Division of Cognitive Neuroscience and Director of the Johns Hopkins Alzheimer's Disease Research Center. Over the course of her career, she has conducted several large longitudinal studies aimed at improving our understanding of Alzheimer's disease, the most recent of which is focused on the earliest phases of Alzheimer's. This work uses biomarkers based on imaging, cerebral spinal fluid, blood, and genetics to better understand the earliest phases of AD. In addition, she has a long-standing interest in the study of lifestyle factors that influence the risk of cognitive decline as people age. Dr. Albert has authored over 300 peer-reviewed publications and received many awards for her contributions to AD research. Most recently, the Henry Wieniawski Lifetime Achievement Award, given by the Alzheimer's Association in 2019. So with that, I will turn it over to Dr. Albert, give her a moment to share her slides. And if you found the Q&A, it's at the bottom of most devices. If it's not, you can scroll up to the top and it should be there.
So thank you so much, Kate and Connie. Can you see my slides?
Yes.
Wonderful. All right. Well, I'm really pleased to talk to all of you this afternoon about recent advances in Alzheimer's diagnosis and treatment. As you heard, there are many diseases that cause dementia. I have a list of most of them on this slide. Alzheimer's disease is at the top, not just because it begins with A, but because it's the most common dementing disorder. We believe it represents about 70% of all the cases of dementia. And typically, when this occurs among older people, the pathology of Alzheimer's disease is not alone by itself, but there are other comorbidities such as vascular disease or something we call Lewy body disease. But really, overall, the primary cause of dementia in the world is Alzheimer's disease. And that's why over the last few decades, that's been the form of dementia that's received the most attention. So what I'm going to be doing this afternoon is give you a very brief history of the original description of the disease and talk a bit about the way our concepts of it have changed over many decades, give you a sense of the underlying neurobiological changes associated with Alzheimer's disease, talk about current diagnostic procedures, and then progress in finding improved treatments, and then just some sense of where things are going in the future. So as you may know, the earliest description of Alzheimer's disease was in 1906 by someone named ALZ Alzheimer. But we believe that the disorder has always existed because when you read documents from, 1,000 years ago, you hear descriptions that sound as if they're talking about Alzheimer's disease. But when Dr. Alzheimer's first saw his patient was young, and then people ended up thinking that this was a rare disorder. This is a picture of Dr. Alzheimer's first patient. She looks as if she's quite elderly, but in fact, she was in her late 50s at the time. And she came to him because she had been having progressive decline in mental abilities. So she was having increasing difficulty remembering things, helping to function independently. She also had a number of psychiatric symptoms, such as suspicion of others and agitation. And he was very interested in what might be causing this disease. And it turned out that when she died, he was able to examine her brain because he had a number of colleagues who were working with him who made some very novel developments. So this picture I have here is of the colleagues that Dr. Alzheimer had. He's the individual who's standing to the left of the person in the white coat. But in fact, part of the reason that there were all these changes in understanding the disease is because all of these individuals were working together. And one of Dr. Alzheimer's colleagues developed a new stain for brain tissue, and another one developed a new microscope. And that's why at the end of the day, when his patient died and he took this new stain and looked at it under the new microscope, he was able to see what we now consider to be the hallmarks of the disease. So this is what he first saw. These clumps that you see are called plaques. He called them that at the time. And these little sort of twisted figures here, he called tangles. And that is the way we think of this pathology to this day. We call them plaques and tangles. And the disease was thought of as being rare, as I said, because Dr. Alzheimer's patient was quite young. But in the late 1970s, there were a number of investigators who started looking at the brain of individuals who were elderly when they died and had dementia, and discovered that they had the same pathology. And Dr. Robert Katzman, whose picture here, wrote an editorial in 1976 called "The Prevalence and Malignancy of Alzheimer's Disease, a Major Killer." And what he argued was that he and his colleagues had seen that looking at the brains of people who died with dementia, the primary pathology was Alzheimer's disease. And what he knew was that the prevalence of people over the age of 65 was getting greater and greater. And he also saw that the prevalence of the pathology was increasing as people got older. So he put this all together and concluded that at the end of the day, Alzheimer's disease was probably the major cause of dementia among older people. And in fact, he was correct. And so starting in 1950, these red dots represent what we think of as the prevalence of Alzheimer's disease at that time. But as Dr. Katzman understood, because the population of older people was increasing by the year 2000, this is where we estimated the number of cases of Alzheimer's disease around the world. And this is where we think the estimate of the number of cases is going to be in 2050. And as you can see, the prevalence is increasing dramatically, but particularly in parts of the world that we think of as third world countries. And that's because people are going to be living to older ages. And this is a disease that's common as people get older. So how do we diagnose the disease? Well, the only definite way we have to this time of diagnosing Alzheimer's dementia is looking at brain tissue, just the same way that Dr. Alzheimer did. So if you know that somebody had dementia during life and you can examine brain tissue when they died, you essentially count the number of plaques and tangles, not so dissimilar to the way that Dr. Alzheimer did in 1906. So you might see on some aspects of the brain tissue, very few plaques and tangles, but in some regions you see very many, and you use that sort of counting system to decide whether or not somebody meets criteria for Alzheimer's disease. But the clinical diagnosis is not considered definitive at the present time. We're getting closer to that, but we have a little bit of a ways to go. It's considered to be possible or probable. And when people started focusing on Alzheimer's disease in the modern era, which was shortly after Dr. Katzman published his editorial around 1980, the focus was on how do we diagnose Alzheimer's dementia? So when people have progressed to the point where they are really not able to function independently, what kind of method should we use to diagnose this condition clinically? And there was a seminal publication in 1984 that said that really what we're talking about is progressive decline in mental abilities to the point where an individual can no longer maintain their independent function without assistance. By definition, it has to be a decline from a prior level. And what was said in this publication was that 2 or more areas of mental ability needed to be impaired. For example, memory and language, or executive function and spatial ability, something of that sort. Over time, this way of thinking has come to be thought of as a two-step procedure. First, is this syndrome of dementia present? So do we see that there's a gradual decline in cognitive ability to the point people are not independent? And can we figure out what the etiology is, what the cause is? And most of the time we do this by ruling out other causes of dementia. Does this person have an infection in the brain? Have they had a head trauma? Do they have a vitamin deficiency, a metabolic disorder? So when you go to a physician for a diagnosis, they're looking for these other kinds of conditions that might be causing dementia. And if you are able to say the syndrome is present and you've ruled out other things, then the diagnosis is considered to be either probable or possible Alzheimer's dementia. Over time, when people began to study this disorder much more frequently, what clinicians began to see was that many patients were coming into their clinic who didn't meet the criteria for dementia, but had progressive declines in cognitive ability. They were still able to maintain their independence, but they certainly had evidence of changes. And over time, the term for that condition became MCI, or mild cognitive impairment. In the United States, we use that term. In other parts of the world, they sometimes use the phrase prodromal Alzheimer's disease, but it essentially means this intermediate phase where people are having declines in mental ability, but they're still able to maintain independence. And the way that we diagnose that clinically is exactly the same way as we might diagnose somebody with dementia. We're looking to see if there are progressive but mild declines from a previous level of function, but somebody is still able to compensate for those impairments. And we do it by the same two-step procedure. Is this syndrome present? Do we see these gradual declines that are clear, but somebody is still managing independently? And can we rule out other causes for this? That somebody doesn't have a tumor, doesn't have an infection, doesn't have a traumatic brain injury, what have you. In very recent times, these diagnostic methods have been updated to include a phrase you heard earlier from Kate, the term biomarkers. So now when we want to say, is dementia or mild cognitive impairment due to Alzheimer's disease, we would ultimately want to see evidence of underlying pathology based on biomarkers. And a biomarker is an indirect reflection of this underlying pathology of the plaques and tangles that I talked about. So how do we do this in real life? Well, now we know, after many decades of studying, that the plaques and tangles that Dr. Alzheimer saw contain substances that we can measure, specific proteins. And the plaques primarily contain a substance called amyloid, which many of you may have heard about. We sometimes refer to it as amyloid beta or A beta. It's a particular form of amyloid. And the tangles contain a substance called tau. And we know now that we can measure these things indirectly, either from cerebrospinal fluid or from imaging. So this is just a picture of what we now know about the plaques with this primary component of amyloid, and the tangles, you see this tau or phosphorylated tau. And when we look at cerebrospinal fluid in the brain, it turns out that we can get a pretty good reflection of these proteins. We can see whether they're accumulating in the brain. And so you can do a spinal tap and you can get cerebrospinal fluid, and you can measure this A beta 42 or phosphorylated tau or tau to see whether or not there's evidence that amyloid and tau are accumulating in the brain. So sometimes when people go to a physician and they get a diagnosis of possible or probable Alzheimer's disease, they might say, I want to know if there's any more definitive information that can be gathered. How could I do this? And one way is to have a spinal tap where you could collect cerebrospinal fluid, and it has to, of course, be sent to a very special laboratory that does these studies. Another way that you can now evaluate whether or not amyloid is present is with something called amyloid imaging. And this is has been around since maybe 2003, but starting in 2012, there are several tracers that have been approved by the FDA that are confirmed to measure amyloid. One of them is this image that I'm showing you here, what originally was called AV45. There are several other tracers. They are measured by what's called a PET scan or positron emission tomography. PET scanners are available in many major medical centers. The biggest difficulty with getting this way of evaluation of amyloid is that it's quite expensive right at the moment. Although these are approved by the FDA, the Center for Medicare and Medicaid Services doesn't pay for the PET scans, and so they're quite expensive. But this is another way of trying to certify that what probably is happening in the brain when somebody meets these criteria for dementia or mild cognitive impairment is underlying Alzheimer's disease. So we now know that there are lots of people with the disease, that if there aren't effective treatments, there are going to be many more. And so in general, the scientific community has been spending a great deal of time trying to figure out how to find better treatments for Alzheimer's disease. This has been a major effort ongoing really since about 1980. And we now know that the disease has this long course. And so originally when people started looking for treatments of the disease, they focused on people with clinical dementia, and they tried to figure out if there were drugs that could improve the symptoms and delay progression of the disease. And there were ultimately 4 drugs that were approved for the disease. There was actually a 5th, but it's really not one that's particularly relevant. 3 of them act by increasing levels of acetylcholine in the brain. One of them is an NMDA receptor treatment. They all act by giving somebody improvement of about 6 months over what they would be without that treatment. We know that they don't prevent the progression of the disease. They just make the symptoms slightly milder. All of these drugs, time and time again, when they've been tested in clinical trials, have been shown to be effective from the perspective of making somebody less impaired for a period of time. And that's why they have been on the market for really many decades. But you may know that, and have probably heard that just very recently, within the last year or two, there's been a lot of progress in Alzheimer's disease clinical trials, particularly for people with mild dementia or with mild cognitive impairment. And there are really 3 drugs that you may have heard about recently. One is called aducanumab, another is lecanemab, and the third is donanemab. And aducanumab, you probably heard about 1.5 years ago. Lecanemab maybe 6 months ago, and donanemab just this last week. So this is a very rapidly changing field. I'm going to just talk about the information we know about lecanemab, because the donanemab data is very recent and it really hasn't been published. And there was a lot of controversy about the aducanumab data. And so I think it's best to focus on lecanemab, give you a sense of what's been learned and what maybe that means in terms of future treatments. So this clinical trial with lecanemab, as I indicated here, was run by Eisai. They called it Clarity AD. And essentially what they did was they randomized people with either mild dementia or mild cognitive impairment to treatment or to placebo. And the treatment was given by infusion, and the goal of this treatment was to clear amyloid from the brain. And the infusions had to be given every other week, so that's very frequent. And in the clinical trial, it lasted 18 months. And the first thing that they looked to see was whether or not there were changes in the accumulation of amyloid in the brain. And if you see here on this image, the places where there's a lot of red, that shows the accumulation of amyloid. And the question was whether or not this treatment would clear some of the amyloid from the brain. And in fact, it did quite significantly. If you look at this figure here, the line going down with all the asterisks shows you that amyloid started being cleared almost from the time people started taking the drug and decreased to almost normal levels after 18 months. And the images of the scans on the right are intended to give you some sense of how much was cleared, but it was really quite a significant decrease in amyloid that was seen. The really important thing is that in addition to clearing amyloid, there were significant changes in the level of cognition and the level of function among the people who were getting treatment versus people getting placebo. And the top line is the people who were receiving the treatment. The bottom line is the people who were getting the placebo. And you can see that there was this gradual separation over time, so that by 18 months, there was what we call a statistically significant difference, or a 27% slowing in this measure of, which was a global measure of cognition and function. In addition to this measure, there were other specific tests of cognition showing essentially the same thing, that various ways in which you would measure somebody's mental abilities all seem to show that people on treatment were doing better than people who got placebo. Interestingly, although this treatment was designed to clear amyloid, it also seemed as if it was changing levels of tau. And the levels of tau were just measured with plasma, well, and CSF in some of the groups. So in small numbers of people, but still showing that there were these changes in tau as well. It's important to know that this treatment does have side effects, and all of these treatments do. And the primary side effects that are found in these infusion methods of clearing amyloid are called amyloid-related imaging abnormalities, or ARIA. And this involves either swelling of the brain or small microhemorrhages that are seen on MRI. And you may know that the major genetic risk factor for Alzheimer's disease is called ApoE4. There's a gene called ApoE that has 3 different versions that we call ApoE2, 3, or 4. The 4 version increases risk for Alzheimer's disease, and people who were ApoE4 had more side effects with this treatment than people who were not ApoE4. So what did we learn from this clinical trial? We learned that this drug could clear amyloid from the brain to almost normal levels. There was a statistically significant benefit in all of the major endpoints that have to do with cognition or function over this 18-month trial. But the benefit by most clinicians, I would say virtually all clinicians, is considered to be modest. It was on a score of 0.45 on the CDR sum of boxes, which is 0.5 would be considered maybe clinically meaningful. So it's just on the border of being clinically significant. And there were side effects in about 26% of the people who were taking the drug, as I said, particularly significant in people who were ApoE4 carriers. So what about the potential use of this drug? It has been it has received accelerated approval by the FDA, and I think we are anticipating, if the reports about donanemab are similar, that it will also receive accelerated approval. But this means that it will only be approved for people who are similar to those who were in the clinical trial, either people with mild cognitive impairment or mild dementia who were amyloid positive initially. So that means that what's going to happen is that if you had mild cognitive impairment or mild dementia, and you would have to go to a physician, you would have to get an official diagnosis, and you would have to get some measure of amyloid to show that amyloid was present in your brain, because that's who the drug was given to. And of course, the purpose of the drug was to clear amyloid, so that makes a lot of sense. Right now, you would have to get infusions every 2 weeks. The company is trying to develop a way of giving the drug subcutaneously, but at the moment it means you have to get infusions, and you have to have repeated MRI scans over the first few months to look to see whether or not you're developing these side effects that we call ARIA. We're not yet sure whether or not Medicare will cover this treatment. The anticipated cost of the drug is $26,000 a year. That's because that's the cost of the drug. And then on top of that, you have to have the cost of the physicians, the cost of the infusions, the cost of the MRI scans. So it's going to be, a reasonably expensive undertaking. But so that's where we stand with lecanemab. Donanemab, as I said, was just reported as having a positive effect just this last week. The results look very similar to what I'm describing here. There are some subtle differences. I didn't decide to present anything about them here because we only know what's been reported in the newspapers. We haven't seen yet an official publication with all the details. And because the two seem to be very similar, I thought that I would focus on lecanemab. And my guess is that overall the picture is very similar from your perspective. But while all of this work has been going on in treating people with mild dementia and mild cognitive impairment, it's become clear to people in the field that actually Alzheimer's pathology begins when people are cognitively normal. So starting quite a number of years ago now, there were several different studies, mostly looking at brain tissue from people who came to autopsy who were cognitively normal when they died. And what these studies found was that about 20 to 30% of them had Alzheimer's pathology in their brains when they died, despite the fact that they were cognitively normal. And the reason we think that they were cognitively normal is that there was not a lot of nerve cell loss. That the pathology was, Alzheimer's pathology was present, but the nerve cells still were very robust. And that's why people didn't have symptoms. And now that we have amyloid imaging, we see similar percentages of people who are cognitively normal who have amyloid in their brain. And this percentage of individuals who have Alzheimer's pathology is directly related to age. So if you look at people in their 60s, there are very few normal individuals who die with Alzheimer's pathology. At older ages, the prevalence is much higher. And this is just a sort of a pictorial image to show you what we're thinking about right now in terms of the evolution of the pathology of Alzheimer's disease. That it really begins when people are normal, that it starts to spread through the brain during this prodromal or mild cognitive impairment phase of the disease, and then of course becomes much more extensive when people have full-blown dementia. So there's really a consensus in the field that Alzheimer's disease has this very long phase over which it develops, probably decades, that people go through an intermediate phase where they have symptoms, but they don't have dementia, which we call mild cognitive impairment, and that individuals, a subset of individuals who are cognitively normal, have Alzheimer's pathology in their brain. And so that's what has led the whole field to think that we really need to focus on early intervention. And that likely, if you start to treat people who have MCI or dementia, you might get some benefit, as we see from these recent clinical trials. But ideally, what you would want to do is intervene when people are normal, before there's full-blown nerve cell loss and before people develop symptoms. So that's where the field is kind of going right now. Many people in the field are trying to study what we call preclinical Alzheimer's disease, or this phase before people develop symptoms. We do this by recruiting people who are cognitively normal, primarily middle-aged, because there's evidence to suggest that these brain proteins begin to accumulate in middle age, and collect a wide range of measures, these biomarkers that are going to tell us about the underlying pathology in the brain. And what you'd like to do is follow people long enough that you could see that some of them had progressed, and you could use the information collected when they were normal to begin to tell you, could you predict who was going to develop the disease and who should have treatment if you had really effective treatments. And I'm just going to tell you very briefly about one such study, because it happens to be a study that I direct, but there are a number of other studies around the country that are similar to it now. So this is a study called the BioCard study. It was begun at the National Institutes of Health in 1995. We then inherited the study in 2009. And in fact, right now we're recruiting additional participants. But the original cohort was middle-aged, as you can see. The average age was 57, about half male, half female. This was a very well-educated group. The racial composition was largely Caucasian, because at that time in 1995, there was much less emphasis on trying to increase the diversity of the research participants, which we now are trying to do as we're recruiting more people now. And by definition, the investigators who started the study wanted about 75% of them to have a family history of dementia. And that meant that about 34% of the population was ApoE4 positive, because there's this relationship between ApoE4 positivity and the accumulation of amyloid, as I said. And of course, as you might have guessed, the big emphasis in this study is on biomarkers. So you want to collect biomarkers because in a disease that's progressing so slowly, you need some indirect measure of what pathology is developing in the brain. And by definition, if people are normal, have very minimal symptoms, that's the way that you're going to primarily see how things are changing. This is just a graph of the study timeline when the phase of the study was at the NIH, and it's now at Johns Hopkins. And we collected a large range of biomarkers. So cerebrospinal fluid, because as I said earlier, this is really an outstanding way of measuring the proteins in the brain related to Alzheimer's disease, this amyloid and total tau and phosphorylated tau. Magnetic resonance imaging, because it gives us an indirect measure of nerve cell loss. Cognitive testing, as positron emission tomography came along, then we started to add that. And very recently now, we're looking at measures of amyloid and tau and phosphorylated tau in blood plasma, which is the new hope for an effective biomarker. This is just a table showing you that we've collected a lot of things. I'm not going to spend any time on it, but I do want to give you a sense of what we've learned. So we know now, as I said, that from measuring these proteins, amyloid, phosphorylated tau, and tau, we can get an indirect reflection of underlying Alzheimer's pathology. And if we measure this in people who are cognitively normal, we can see that over time it relates, the levels of these proteins relates to who develops symptoms many years later. These figures that I'm showing you, as the lines separate, it means that the people with or without these proteins are different in the time it takes for them to develop symptoms. And I'm showing you 2 independent studies that tell us that even when people are normal, we can measure these proteins in their brain, and it's related to how long it is before they develop symptoms. We see something very similar when we measure MRI scans, particularly the parts of the brain that have to do with memory. If we measure certain regions in the brain in people who are normal, it's related to how long it takes for them to develop symptoms of mild cognitive impairment. And also cognition. So even though these people are normal, within the normal range, where people perform is related to the likelihood of developing symptoms many years later. So this is just kind of the beginning of trying to figure out, can we use these kinds of measures in people who are normal to figure out who's most at risk, and if we had an effective treatment, when we would intervene. So in terms of future directions, really the success of lecanemab and donanemab is very important for the field because there were so many decades of clinical trial failures. We were very, very worried that without any successes, a lot of the pharmaceutical companies would really give up. In fact, some of them did give up making any efforts to develop drugs for Alzheimer's disease. And so these successes are really critically important, even though it seems as if the benefits are clear, they're modest, but they're statistically significant and very meaningful. With seeing that just the treatment of removing amyloid makes a modest effect, there's increased interest in combining therapies, maybe treating not only reducing amyloid, but tau. And that continues to make the understanding of the earliest phases of the disease really, really important. Because if these drugs are effective, you're going to want to intervene when people are normal but are at high risk. So really where the field is going is that people are going to continue to examine the earliest phases of Alzheimer's disease. They're going to continue to work with individuals, looking at clinical and cognitive assessments and biomarkers. And also there was some mention of lifestyle factors. I don't have time to talk about that today, although I'd be happy to answer questions, but there's an increasing interest in, can you look at lifestyle factors that might also reduce the risk of cognitive decline, such as vascular risk, physical activity, or cognitive activity. There's a lot of work going on in finding new biomarkers. So the ones I've been describing have been known for a really long time. And we at Johns Hopkins have found one, which we call NPTX2. There are groups around the world that have identified others, because if you found other biomarkers that were really important, those could also be a target for treatment. And we're working very closely, if we can, with the companies that are working to develop treatments, because the knowledge that we have can help them figure out when to start treating people and what targets they might develop in terms of finding better treatments to reduce Alzheimer's disease and hopefully prevent its progression going forward. So let me stop there. I'm happy to answer any questions that people have. I haven't been looking. I guess I don't know that I could see the chat, but
yeah, no, thank you, Dr. Albert.
I would be happy to answer any.
Thank you. And just a reminder for everyone tuning in, there is a Q&A feature that's different than the chat. So I'll be focused on what's coming in through the Q&A, and we have several already. I'll go in order. I would like to know how to deal with a parent who has AD.
So if this is somebody who does not have a diagnosis yet, but you expect a diagnosis, then obviously the most critical thing is to get a diagnosis from people who have a lot of skill in that area. Needless to say, we have that skill at Johns Hopkins, but there are lots of other places too that have physicians with expertise. My own feeling is that it's really important to get a diagnosis because this is a disease that lasts a really long time. A lot of people who have it develop behavioral symptoms that are sometimes challenging to treat. And places with expertise also know a lot about it. And they also know a lot about services that are available. So I think the key is to get good medical care and follow up and look for all sources of information. I haven't mentioned the Alzheimer's Association, but that's certainly an important source of information. Their website is ALZ.org, ALZ.org, and lots and lots of information all the time available on that website.
Thank you, Dr. Albert. And I'll make sure to put a link to the Alzheimer's Association in our
Okay.
follow-up email. Next note is my father and grandmother died of Alzheimer's. I have had cognitive decline for years. I've tried to simply get cognitive testing. I'd like to start medicine while I still can, but until you have serious signs, they won't give you tests. I've been told there is nothing to do or nothing you can do anyway, and it is so frustrating. I can't access the new tools for early diagnosis and treatment, and time is running out.
So actually, now that we have these drugs that I've been talking about, lecanemab and probably donanemab as well, those drugs are available for people with mild cognitive impairment. They would be prescribed if it seemed to be appropriate by a physician. So there are lots of places that would give somebody an evaluation that has changes in cognition over time. We have a clinic at Johns Hopkins. It's the Memory and Alzheimer's Treatment Center. Lots of places would be happy to give you an evaluation. And if somebody meets criteria for mild cognitive impairment, likely very soon, they'll be able to take these drugs. Now, as I mentioned, right at the moment, they're quite expensive. But I'm guessing that the Center for Medicare Medicaid Services might begin to cover them in the not too distant future, but at least getting a good evaluation and a good diagnosis is important. I would mention that, you know, as I said about diagnosis, part of what we do is rule out other causes of cognitive decline. So we do blood tests to see if there's something wrong with your kidney or your liver. We look at brain scans to see if there's a tumor, if there's a lot of vascular disease, a lot of other things other than Alzheimer's disease that might be causing cognitive decline. And many of those things are treatable. So it's really important to get a good evaluation. And I think any memory center would be happy to do that.
Thank you. And I'm assuming this next question was in response to your talk about one of the studies. Was there a reduction in amyloid improve cognition? Did reduction in amyloid improve cognition?
Well, what people saw in the two studies that I mentioned. So I talked about aducanumab, but the clinical results from that were questionable. But for lecanemab, and we think also for donanemab, there was a big decrease in amyloid, and there was a significant change in cognition, a slowing of decline. There were the people, as you saw in those curves, I can go back to them if that would be helpful. Let's see here. So you see here, everybody was to continue to decline. It's not as if on average, one group remained stable and the other one didn't, but one group declined at a slower rate. And that's essentially what was found in this particular clinical trial. And it sounds from the reports as if that's true also for donanemab.
Is it confirmed that amyloid and tangles cause Alzheimer's, or are they symptoms of the disease?
We do think that they cause the disease. We think that what happens is that when they accumulate in sufficient quantities, they begin to kill nerve cells. If they're there in very modest amounts, then the nerve cells are able to maintain robust function. But when there's enough accumulation, they begin to destroy nerve cells. I mean, there's no way to definitively prove that other than, I guess, removing it and seeing that there's an improvement. So the more that we have successes in these clinical trials, the more we could say there's causation, but certainly everybody in the field believes that those two things in combination is what's killing nerve cells, which is then making people decline in their mental abilities.
In the lecanemab trial, did the patients maintain their improved function when the treatment stopped?
That's a really good question, and we don't know the answer to that. The company is continuing they made the drug available to people who wanted it when it was over, but we don't know yet what they have found. And one of the more intriguing things, as you could see from that slide, is that those two lines seem to be separating more and more over time. So you might guess that there would be even an increased benefit by taking the drug for 24 months or whatever, but we don't know the answer to that question yet.
Is Alzheimer's genetic?
There is a genetic component to Alzheimer's disease. So there are two ways in which it's genetic. One is very, very, very rare. So there are what we call dominant mutations in certain genes. If you have that mutation, you will almost certainly get the disease. So people who are in families with these mutations now really know it, because they know that one of their parents had the disease and their parents had the disease and had it quite young. So most of the people who have these dominant mutations develop the disease when they're extremely young, sometimes in their 30s and 40s and 50s. But there have been some clinical trials with individuals like this, which were not successful. It might have been the drug, we don't know. But most people don't have these mutations. Most people have what we call risk genes. And the one I mentioned before, apolipoprotein E, that's the major risk gene. And it's the 4 form that increases risk. But we know there are other genes as well. And any one person has a combination of genes. Some genes are protective. So for example, ApoE2, the 2 form of this gene, is protective, and the 4 form increases risk. So everybody has some combination of genes that increase risk or decrease risk. So we know that genetics plays a role, but among people who don't have these dominant mutations, the genes are not deterministic. In other words, you're not going to get the disease no matter what. So we believe that there are lots of lifestyle interventions that might make a difference.
Okay, well, with that, I'm going to skip one question for the moment, because the one after that is, are there lifestyle changes that can help lessen one's risk? Already in their minds.
Yes, so I mentioned 3 on that slide at the very end. So one is vascular disease. People who have high blood pressure, high cholesterol, diabetes, who smoke, who are overweight, increase the risk that there will be changes in the vessels in their brain that carry blood to the brain. And so we call these vascular risk factors. And people with a lot of those vascular risks have changes in their brain that change cognition, that change mental abilities. We believe that if you have some vascular disease and some Alzheimer's disease, the effect is sort of additive. In other words, you might, without the vascular disease, if you just had a small amount of Alzheimer's disease, you might not have any symptoms, but with both together, you're more likely to be impaired. And we have treatments for vascular disease. And so that's why one of the most important messages that we can get across is the importance of controlling vascular risks, because these are things we know a great deal about. There is some evidence that cognitive activity, being more cognitively active and cognitively engaged, reduces risk. This concept is called cognitive reserve. We're trying to learn how to measure it and how important it is, but we can see that people who are more cognitively active throughout their life are at lower risk for cognitive decline as they get older. We don't know whether or not, if you weren't cognitively active when you were young and you started to be when you were older, or, you know, vice versa. We don't know enough about those details, but there's beginning to be a lot of study about that. And then physical activity is the other one that I mentioned. And there's a good deal of evidence that people who are more physically active have a reduced risk of cognitive decline. And again, we're trying to figure out what kind of physical activity, how much, at what age is this. We think it's not just that you're improving the blood flow to the brain. We think that it's having some effect on these proteins that have to do with Alzheimer's disease, but there's a lot more we need to learn about it.
All right, thank you, Dr. Albert. And I do want to respect your time. We have over 25 questions more coming in. I'll have to cut it off eventually, but please let me know. I'll keep reading them until you must cut us off. So the next one is, I was told that a speech pathologist can use a series of tests to determine a diagnosis of dementia. Is this true?
So people have thought that certain speech patterns might be associated with a greater likelihood of cognitive impairment. I would say that this is a field that's evolving, and we have a lot to learn yet. So it's not the way I would diagnose the disease if you left it to me.
Okay. Here's one that I think is probably on a lot of people's minds. Are you looking for folks to join your study?
We are indeed. So this BioCard study, as I said, we're looking for people who are cognitively normal and who are willing to participate in all the study procedures, which of course means not only clinical and cognitive assessments, but this collection of biomarkers. We feel like what we're doing is really special because the information we have is telling us so much about the earliest phases of the disease. So if you wanted to help, we would be happy to talk to you. Also, of course, there's a lot of other research going on in our Alzheimer's Center. And if it turned out that our study wasn't optimal for you, we could point you in the direction of other studies that you might be interested in. So people should feel free to, I mean, maybe Kate, the best thing would be to send my email and people could contact me.
Absolutely. And it is for those who can see the screen right now, BioCard
that's not that. So that biocard-se.org is where you could get more information about the BioCard study. And if you looked really carefully, it would give you the email from my nurse coordinator, but probably an easier way, if you knew that you wanted to pursue this, would be to send me an email. And
well, then thank you. There. Direct to the source. I love it.
But you could get more information about the study on that website.
Great. Can one only go to a neuropsychologist for a diagnosis, since my elderly parent refuses to do an MRI and couldn't lie down due to dizziness for a CT scan?
So what you would want to do would be to go to, so in our memory center, for example, we have neurologists, neuropsychologists, psychiatrists, and geriatricians. and all of us work together and help to diagnose patients. So it could be a neurologist, could be a psychiatrist, could be a geriatrician. Mostly you want to be sure to go to a place where they do a lot of this, where they see a lot of patients, so you can be sure that the diagnosis you're getting is accurate and that you have access to the most up-to-date information. And again, maybe if people wanted, we could send them information about the various centers that are around where they could contact, medical professionals, if that would be helpful.
Yes, please. Any news on less invasive diagnosis?
So I mentioned briefly about blood biomarkers, and that's, I think they're around the corner. So there are several companies that are developing blood biomarkers. We think so far they're probably not quite as accurate as cerebrospinal fluid, which of course is not surprising because we're trying to measure something in the blood that's coming from the brain. But for example, in our study, in the BioCard study, we sent blood samples that had been collected over 25 years to one of these companies, and the data that we've gotten back is very, very encouraging. So I do think that blood biomarkers are going to be available soon, mostly initially for research, because what the companies are trying to do that are developing clinical trials is see if they can measure something in blood that will tell them who are the best people to enroll in their study, because obviously PET scans are very, very expensive and they're trying to avoid that. So blood biomarkers are coming down the line, and they absolutely are going to be obviously much not invasive at all.
Okay. What is the current theory about why the plaques and tangles appear, and how precisely these relate to the damaged brain?
So that's the $25 billion question. We don't know. We know that the plaques and tangles begin to develop early. So I didn't show you a slide from my colleague Juan Troncoso, but it's a wonderful study that he did years ago, where he had over 300 brains from the medical examiners in Maryland. And he found that tau begins to develop when people are in their 30s, in the part of the brain related to memory, and then it increases in deposition over time. Amyloid actually begins to develop when people are in their 40s, but at that age, primarily in people who have this ApoE4 allele. And both of those two things seem to go on independently. And what we believe happens is that at some point there's an interaction where amyloid has accumulated enough that it accelerates the production of tau, and those two things together are what lead to nerve cell loss. But why that starts to happen initially, we really don't know.
What do you think of the new blood tests for Alzheimer's that have been in the news?
Well, as I indicated, there are blood tests that are being tried, and we're using them in research, and we're learning more about them. I think right now everybody considers them to be important for research. All they will do, if you're taking them out in the community, is to say something about your likely accumulation of these proteins, but they really can't be used right now as a diagnosis because we don't know enough about them. But certainly we will in the future, and we will be able to say this test at this level means the same thing as if we were measuring it in cerebrospinal fluid or in positron emission scans.
Is there a reliable resource to use for lifestyle factors?
So I would send you to the website for the Global Council on Brain Health. So this is an arm of AARP, and I think it is, I should know the website. global, I can't remember it. I can send it to you, but
Yeah, we'll find it.
the Global Council on Brain Health was established by AARP to try to get as much evidence-based data about lifestyle factors that might be important for brain health. And they're making it their mission to publish qualified information that's as informative and accessible as possible. And I think that's the best resource for people.
Great. Can you
And
distinguish?
Kate, we're maybe one more question.
Sure, absolutely. Can you distinguish between AD and dementia?
Yes, so I'm surprised I didn't get that question earlier. So dementia is an umbrella term that refers to all people who have progressive cognitive decline to the point where they're not able to manage independently. And Alzheimer's disease is the most common form of dementia. So it is a dementia, it's just a particular one. And so we don't distinguish from them in that sense. In other words, Alzheimer's disease is a form of dementia, and now we talk about dementia due to Alzheimer's disease or mild cognitive impairment due to Alzheimer's disease. So it's the specific pathology in the brain. It's the major cause of dementia in the world.
Fantastic. Thank you, Dr. Albert, for staying a little extra. Thank you all who tuned in today and asked such wonderful questions. We will have a really thorough follow-up with all these resources. We'll have a recording so you can watch again, let it absorb, share it with friends and family. And for those who are available this weekend, there is a conference on Alzheimer's and dementia and memory care sponsored through Sibley Memorial Hospital. So please check that out. That was in your reminder. I'll send that out once again. And thank you, everybody. As I mentioned before, there will be a link to a very short, brief evaluation, but what you share is so important. It helps us continue to offer this wonderful, very specific programming. So please take a moment to complete that this afternoon, as it will pop up when you log off. Thank you, Connie. Thank you, Friendship Heights Neighbors Network. Thank you, all of the Montgomery and Washington area villages. And again, Dr. Albert, thank you for all your work that you do and advancing this such an important topic for all of us.
Well, it's my pleasure to have talked with everybody today, and I'm delighted to have such good questions and such interest.
Yes.
And anything that I can do to help, let me know.
Absolutely. There will be more memory care topics in our future. I already know. So thank you.
Okay.
All
Bye-bye.
right, take care, everybody.